We record our sessions, which is how you can find them online on our website, including all the resources that are attached to those sessions. All right, if you want to go one more, we just talked about that. And with that, it is my absolute pleasure to introduce one of our fantastic community members, Dr. Silvia Russo, a cognitive neurologist at Providence over in Spokane, who has been part of our community for the last year plus and is offering amazing services over in the Spokane area. And I'm going to hope that the sound issues and everything is just fine. Dr. Russo, I'll turn it over to you. Go ahead and take it away.
Hello, everyone. Can you hear me better? Can you hear me? Yes, it seems like on the Zoom you can hear me, and Dr. Rhodes, you can hear me as well. I'm going to go ahead and share my screen. And I trust that you can see the slides correctly. Yes, perfect. So I'm thrilled to be here presenting to you all for a topic that's really near and dear to my heart. And what better way to start? And again, as Dr. Rhodes said, I had no relevant relationships to disclose, and what you're going to hear is basically my experience working in Spokane and the expertise that my patients really have taught me and their families. And so what better way to start this than with a case presentation? And I've chosen a pretty common prototypical case so that we can start with the building blocks of how would you approach it in your own primary care clinic, maybe in a rural area where there may not be neurologists available to you. How can you help John, who's a 75-year-old right-handed retired teacher, and he's really pushed into your primary doctor's clinic. He's missed some appointments with you, and his family brings him to you because of quote-unquote memory issues. And so you decide to ask a couple more questions, and you find out from family mostly that symptoms started around 4 years ago, very mild, occasional forgetfulness, which then piles up and becomes more, and then he starts struggling for words, losing train of thought when he's speaking, and maybe a little more distracted as well. And in the past year, it definitely got worse. And finally, family convinces John to talk to his primary doctor about it. Past history, he's got some hypertension and coronary artery disease. He had a stent placed in 2021, right around when the symptoms started happening, and some high cholesterol, prediabetes. He has sleep apnea, decides not to wear his CPAP. That old thing bugs him, that's what he says. And he has some prostate issues. He drinks about 2 drinks per day, has always done so, stopped smoking a long time ago, doesn't exercise much, a homebody. He does not quite remember his medications, but his wife has a list, thankfully, and these are his medications. And so I'll let you read them and think on them for a little bit. You have time to do a MOCA, and he scores a little low, especially for a teacher. And most trouble was with memory. And when you give him the cues, one was a part of your body and one was a type of fabric, he was kind of guessing. He didn't really remember them. Rest of the exam is benign. You don't see any tremors. You don't see any walking problems. He just had a little hard time hearing you. He's not quite sure why his family is all worried, and he says, I'm just getting old. He's always been in charge of finances, but lately his daughter says, well, I asked him a question about a couple of investments, and he wasn't quite sure, so I'm also worried. He's getting a little bit lost in less common destinations when driving, but no accidents. And his daughter says, well, there is some family history, like his dad had it, and I'm not sure what I can do myself and what we can do as a family to help him and how we, the kids, can reduce our own risk. So you probably heard this many, many times in your clinic. I do hear it a lot by nature. And this is an opportunity. The pitfalls of, addressing this in primary care is that the patients will tell you, especially if they present by themselves, oh, I'm old, it's okay, I don't have a problem. And so that's often a misdiagnosis. About 8% of older Americans with MCI, it's been calculated, receive a diagnosis, so just a minority. And 50% of Alzheimer's patients are diagnosed in late stages. Many patients will never get a diagnosis. And the inequality and disparity is prevalent where some Black and Hispanic seniors are often underdiagnosed. Some primary doctors and some patients also tell me, but why bother? There is no cure. And this is what I consider as the missed opportunity. Prevention. His daughter asked, what can we do as kids to prevent our risks? This is something you do every single day. So unintentionally, you are a key in preventing the onset of dementia by enacting and informing about brain health, which I'm sure you heard about today. Delayed access to treatment, especially in the era of new treatments, this is going to become key to diagnose people early. And even for the treatments that are available now, they really work the sooner you put them on, not in late stages. Planning becomes impossible if you're late. And that generates higher costs of care because now to find help is urgent. And not to mention the emotional burden on the family, the caregivers, and the patients themselves, because then a lot has to change fast. So if this is the only thing you take home from my presentation, it's this: it matters. And what are the pros? What are the advantages you have as primary doctors is, unlike us specialists where we try to have some follow-up, you guys are set up to have longitudinal follow-up with patients. And you can build a trusting long-term relation with the patient and their family. And you can start noticing patterns. For example, a patient that was always on time now doesn't show up or shows up late 4 times in a row. If they're older, think it could be dementia. Worsening adherence. They don't care anymore about their medications. These are all little signs that you can harvest to think about, well, should I evaluate this patient? Medicare now covers an annual visit, and you probably know better than me. What are the cons? Well, we don't have time. There's training needed to know how to administer the MOCA correctly. It can take a long time to do it efficiently. And then once you suspect a diagnosis, many providers may feel like they don't have the right tools to disclose the diagnosis. And then if you need help, there are no neurologists, or it takes 9 months to see a neurologist. And there can be lack of resources in town. So I hope that with these few slides, I can just plant a seed of hope that some things you can do, if not obviously everything. So the daughter asks you, what can we do to reduce the risk of getting worse for dad? And what can I do for myself? You've probably seen this snake diagram today. 45% of cases of all dementia could be preventable if these early, mid, and late life factors were addressed properly worldwide. Some of these are outside of our control, like the pollutants in the air. But as I was telling you, unintentionally, primary doctors are heroes of preventing dementia because you are in power of these cardiovascular risks. And hearing evaluations, vision evaluations, prompting patients and motivating patients to take care of their health, their mood, addressing social isolation in your visit could also be a good thing. The age-old question is, doctor, do I have dementia or do I have Alzheimer's? This is not such a simple question sometimes. The short answer, dementia is an umbrella term. Alzheimer's is one form of dementia, it's the most common form of dementia, but there are many other forms of dementia. It's like saying vision loss versus cataract and macular degeneration. Patients usually understand it. Caveat is that patients are often sensitive to the word dementia. And so I usually address it in the open. I always say, when I say dementia in medical terms, it doesn't mean I'm using the English word dementia. And so rather than saying use it with caution, I say use it with knowledge of what it means. And the first myth to debunk is dementia is not diagnosed based on the score of the MoCA or the SLUMS or any other cognitive screening test. Function is key. How functional the patient is still determines what the terminology and categories are. And I think in primary care, this is a good framework because it can guide you as to what interventions can be done based on the different stages. So I'll start with this newer definition, which is subjective cognitive impairment. I still consider it an at-risk stage. What subjective cognitive impairment means is the patient or the family report some changes, but when you go measure them objectively with the best measure we have, which is a cognitive test, there are no clear changes from baseline. This one is something that you really need neuropsychological testing to determine. So it's a little bit of a niche category. We used to call them the worried well. More and more, we think that this is an at-risk state where some people will actually develop changes. The most common scenario these days, together with dementia, is mild cognitive impairment, which means patient has cognitive changes, but they remain fully independent. And in this case, the cognitive changes are objective. You can determine them in your test or neuropsychological testing. And then there's dementia, which means when those cognitive changes affect the independence of a person. So that's what dementia really means, still to this day. We call it mild dementia when only higher level activities are affected, like paying bills, taking medications, driving. Moderate when the person starts needing more reminders and help with the basic skills like showering. Hey, did you take a shower today? Oh, maybe not. Oh, maybe I should go check. Or dressing or hygiene. Severe is when the patient needs help with everything. That's where a lot of continence issue happens. The person becomes really frail. Why is this key? And again, a little reminder of what the activities of daily living are. Look for changes compared to baseline. This matters in people who, for example, have baseline intellectual disability or other brain injuries. What is changing from how the person used to be? And so instrumental activities of daily living are things that are a little bit more complicated. And then the activities of daily living are the basic ones: feeding, continence, transferring, toileting, etc. Sometimes it can be hard. So a question I often ask is, would you feel comfortable leaving Joan alone for 2 weeks straight and leaving him to deal with everything he needs to? If the answer is, oh no, I would then follow up with, what would you worry about? And if the answer is one or more of these things, think about dementia. Why is function key? Because you can create a framework. So when it comes to subjective cognitive impairment, it's an at-risk state, so you want to maximize on prevention. This is a great state to involve patients in research because we need to know more about it. Same with mild cognitive impairment. In mild cognitive impairment, you can just already start medication, and really important to start the future planning. This is when the person still can make decisions so that they have a choice in it. In dementia, based on whether it's mild, moderate, or severe, the effect of medication changes. So when we look at mild dementia, you focus on support, education. Medication still matters quite a bit. Lifestyle. This is the time where people start becoming withdrawn. So in mild dementia, you want to try and keep an eye on it. Moderate is the longest stage usually, speaking of Alzheimer's in particular, more burden. Many people need institutionalization. Caregiver burnout really starts becoming evident. More behavior changes happen. And then in severe stages, that's when we start downgrading some of the medications. The person is frail, starts becoming terminal. We think about hospice, less is more, and reinforcing the support of the family, because this is a really hard stage to look at. No established treatment still exists for severe dementia, and that's what I have to say when I get these referrals, unfortunately. I know you went over this with prior presenters today. I'm just going to give you my quick overlook. Not everything is memory loss. Patients and families will tell you, John has memory loss, but your job is actually to dig deeper and understand, is it memory loss? Is it an amnestic presentation where there's forgetfulness of information that's rapid, repeating of questions, missing appointments because you forget? Or is it an executive problem where you're not paying attention, therefore you can't remember, or you have trouble processing when too much information is going on? Sometimes people say memory loss, oh, well, he forgets where he's going. That's not memory, that's navigation. Or he forgets faces of people. That's a visual spatial function. He cannot find objects even if they're right in front of him. Well, think of visual spatial. And then forgetting words, like I don't remember the name for a tree, it's not necessarily memory, it's actually a language function. One of my old mentors said, the first exam starts with the history. Listen to how the person is expressing themselves, that's the first exam. Same with the vocabulary around psychiatric presentations, which are very common. Not everything is depression. Late onset of depression, late onset of psychiatric symptoms should cue you that maybe this is a prodrome to a cognitive impairment. What kind of sleep changes are there? What kind of hallucinations? Is it actually seeing something where there isn't, or is it misjudging something that's there, or hearing something that's not there? Trying to get a very clear description of what they are seeing can help us specialists really zone in on who to help first. Apathy is very common, and it can be affecting the quality of life, so it's important to kind of gain some of these symptoms. And psychosis and delusions, we don't have to go too much in detail, but these are just some vocabulary that you can start, putting in your notes and thinking about, because that matters in terms of what the eventual diagnosis could be. Take a look at how they walk. Take a look at whether there are tremors, their tone of voice is softer. You don't obviously have necessarily the time or ability to diagnose motor diseases, but I would say be generous with PT and OT orders. Sometimes the goal may not be to improve like it is for a stroke patient. Sometimes it could be to maintain the function they have. And so don't necessarily wait for the neurologist. If you can put these documentations in your note, hopefully insurance can approve some of these orders. Because if they break a hip and they have cognitive impairment, it's downhill from there. So we're trying to prevent and maintain what we can. And then a little overview of the clinical entities. The Alzheimer's disease is mostly, the classical form is memory affected first, followed by navigation, language, executive difficulties, but it can be atypical in the presentation. It can present with visual spatial first or language first. Dementia with Lewy bodies, oftentimes accompanying Alzheimer's, where there is more Parkinsonism, slowing of the movements, tremor, stiffness or rigidity, with well-formed hallucinations or fluctuations going up and down in their cognitive state unpredictably and acting out of dreams with a visual, spatial, and executive predominant pattern. Vascular dementia, again, a common comorbidity, mostly executive, can be usually very slow or gradual, or sometimes stepwise if they have a lot of strokes that then eat at their function very quickly. Behavioral variant frontotemporal dementia, one of the more common presentations in people younger than 65. This is where the emotional and empathy circuits get affected first, with sparing of memory per se and visual spatial functions. There are some forms of dementia that start in the language center first. And these are important to be attuned to because we can do a lot of help for them in terms of catching it early and planning with them. Parkinson's disease and other Parkinsonisms can also develop a form of dementia. And then this ever-growing population of octogenarians, nonagenarians, I've seen people in their hundreds with a little bit of memory loss as they get older. There are age-related pathologies there that we're starting to know a little bit more about them. So this is more or less a bird's view of all the pathology. And then how can you start working with it? Before even making a diagnosis, you want to get a clear picture. So rule out contributors and try to see how the disease is behaving. First of all, is this truly a gradual change or did it happen truly all of a sudden? The caveat is patients and families will tell you, oh, this happened within the last 2 months. What they mean is the biggest changes happened within the last 2 months. But if really this is something really quick, you have to rule out delirium, medical contributions. Are they making mistakes and taking the antidepressant 4 times a day instead of once, and therefore they have a reaction to that? Seizures are also in the differential diagnosis. Having a knowledgeable collateral informant is very important because they can give you an insight into what their function truly is. And I say ask gently about function because patients get defensive. If you're asked whether you can drive and you think you can drive, it can be a pretty harsh question to ask. And so tactfully try to get at where they are at. Take a close look at everything they're taking, over the counter or prescribed. And I put here a very long list of drugs that I personally don't like. Doesn't mean that nobody with dementia needs them, but I would look very objectively and critically at those and try to find alternatives if you can. And so the reason being for this is if I see a patient who's on 1 or more of these medications, I usually don't add more medications for their dementia. I want to see the clean slate. For example, I see John on oxybutynin, that's an anticholinergic. Even if I'm suspecting Alzheimer's like we all are, I wouldn't put him on donepezil because they will cancel each other out in a way. So polypharmacy is really important. And so you're gonna hear me hammer on this a while. John is drinking 2 drinks per day. That's not a lot. I always say to patients, that's not a lot, but your brain seems to be more vulnerable now. So can we cut back? Can we try to avoid THC, cannabis, or other psychoactive substances? Is there an abnormal thyroid? Yet again, you know, I have less control over how a medication acts if somebody presents with uncontrolled hypothyroidism. So I would urge people to really work hard on this before referring to neurology so that by the time they come to us, we're ready to go. We hit the ground running and we can form a therapeutic alliance and help them quicker. Cognitive screening clinic, I hope that Dr. Gaster has convinced you that it is important. What is their goal? Sometimes I see patients and they're like, well, the doctor sent me here and I don't want any medications and I'm not ready to hear about this yet. So it's important to work with them on formulating the goal. You're going to the neurologist for this and write it down. And then in terms of diagnostics, I know you heard a little bit about it. Just a few points to point out. So we have neuropsychological testing, we have imaging, which can be an MRI, or if you can't do an MRI, a CT, and we have labs. Neuropsychological testing, as you very well know, it's extremely limited and has a long wait list. And then we have sleep tests. For neuropsychological testing, I reserve it to when I cannot find a pattern out. So for example, on the MoCA, if they have a clear pattern of memory loss and the story matches, you may not need a whole neuropsychological testing for 4 hours. But if they just miss one little bit of the sentence repetition, or they got distracted, or they were very anxious, then it could be helpful. Or if the MoCA score is normal, because especially in highly functioning individuals, the MoCA doesn't tell us much. I would avoid sending for neuropsych testing if they score 15 or 11 on the MoCA, because they will not be able to tolerate 4 hours of testing, usually. MRI of the brain, we prefer to have a good quality of the image so that we can see the brain best. So if you have a 3 Tesla machine in your area, I would prefer that. Try to include sequences that look for microhemorrhages. That matters for the diagnosis, for example, of cerebral amyloid angiopathy, and for some of the candidacy to the newer drugs. If you don't have a 3 Tesla machine, do what you have. It's best to have an image than to have no image, because sometimes you will see folks, you will see a large meningioma pressing on the memory centers. You may see areas of inflammation. So it could give you information as to how the brain appears and also rule out other different pathologies. I add contrast when there is a reason. Very rapid presentation. If there is an active or recent cancer that could metastasize, or a very active and aggressive autoimmune disorder, I would definitely consider. For really frail patients who cannot tolerate an MRI, if they have metal, try to get a good CT of the head. I'd like to see general labs in everybody just to see what their general health is. B12 is important because B12 deficiency doesn't help the brain. Thyroid is important in everybody. I add B1 when I see the person is really malnourished, not eating well, or if there's alcohol abuse or use disorder. And then if there is promiscuous sexual behavior, or they might have had a risk. For example, I had a patient with behavioral change who had a sexual encounter with somebody that was a homeless person, and you didn't really know the person well, then I definitely ask for sexually transmitted diseases. And then p-tau is a new biomarker that I wanted to tell you a little bit more about. I've used it myself and I found it useful in select cases. So it is a test that's still out of pocket, but if insurances start covering it, which I hope will be soon, it can help you confirm the diagnosis. It's 89% accurate. I do not use it if patients have chronic kidney disease, because then it can yield false positives. The patient selection has to be important, so it's only for patients above 50 who have symptoms once you've ruled out other contributors. SDG PET scan is an older technique. I still use it sometimes when I need to know which area is working less. It can help with diagnosis. And it can also help with prognosis. So if Alzheimer's is an abnormal PET scan on FDG PET and there is hypometabolism, usually that's a worse prognosis. CSF biomarkers and the newer PET scans are still in the hands of neurologists. I only can hope that in the future they will become more accessible to primary care. You can see here screen of studies that came out in 3 different cohorts where you see the plasma p-tau really associates well with the pathology of amyloid positivity. And some people are saying even tau positivity, the higher it is. So it's a good solid biomarker. I will expect to see it used more often as time goes by, even in primary care. So recommendations for John, back to John. I would recommend starting to work, as we said, on reversible factor. We talked about oxybutynin, he's on Benadryl. For allergies, well, maybe he can use Allegra or another antihistaminergic that doesn't get into the blood-brain barrier. Try to wear the CPAP, you investigate this further, and he forgot to get a new machine because the old machine has been recalled. I'm sure you all had that nightmare of the machines being recalled. So you work on that. You get him into a urine evaluation, you tell him to reduce the alcohol, and you aggressively counsel on lifestyle. You're gonna tell John to exercise, to spend more time with his family and friends, to eat healthy, etc. Potential safety issues, I always counsel on it, even if the patient is early on. I ask him and his family, his loved ones, to keep an eye on medications, driving, and finances. We send some lab tests, and we send for an MRI. These are things you should feel empowered to do in your primary care office, if and when available. 3 months later, he has taken off the medicines, he's using his CPAP, better sleep schedule, meeting up with friends, and he's having ongoing forgetfulness, but overall, they tell you he's feeling a little bit better. His wife is adding spinach and making more soups, and they feel like their digestion is even a little better. What you also notice is that they are looking into the finances a little bit more. And it sounds like there were some mistakes, and now they're helping him. With the change in medication, he feels like he's getting lost a little bit less. But somebody's writing with him from time to time just to check. And then the MRI shows some hippocampal atrophy. I put in here a cut. You see the hippocampi are here in the mesial temporal lobe, and this black space, which is the temporal horns, are a little bit wider. Normally the hippocampi are plumper and there is less black space. And you see also some vascular disease. We excluded strokes and bleeds, but there are some changes in the brain which could be related to the symptoms he's experiencing. Labs are okay, taking his BP at home, it's fine. So the wife asks, doctor, does he have Alzheimer's or dementia? Well, you already know that one, and we'll talk a little bit about how to diagnose John. Can we do something about it? And John says, I don't want to be a burden. So first of all, what is the diagnosis? We have a memory predominant progressive cognitive decline. Something's improved by correcting the reversible factors, but not everything. MRI shows suggestive signs, and patient still needs some assistance with IADLs, the finances, for example, medications. This is mild dementia, most likely due to Alzheimer's disease with some vascular contributions. That would be a good working diagnosis. Of course, things are way more complicated than that in real life, but these are the building blocks. What do you do? His wife says, what can we do? I will continue to hammer every visit if you know me and my patients tell you, I tell them every visit like a broken record, exercise, exercise. And you probably heard from prior lectures, there are newer anti-amyloid antibodies that could be helpful in some, but are a very limited new option. And so not everybody will qualify for that. However, there are older medications that could still be helpful. They're not cures. And the common misconception is, well, it's not doing anything. Why should I keep taking it? Sometimes they can slow down the progression of symptoms and they can give some more cognitive benefits. So I would still consider them. Medication does not prolong the misery. I've had a few patients tell me, why should I take something that delays the progression? I will just be in this state for longer. My answer to that is you will be in a worse state for longer. So why don't we try to keep you in a better state for longer? And that sometimes debunks some of these myths. Local and national support resources. I have a smart phrase if you use Epic, and I print it for every single person, whether they tell me they need it or not. Keep it in your pocket for the future. And then the important thing is I am going to see this through with you. And in primary care, I think there is a privilege to be doing that more often than in other specialists. I am privileged enough to be following patients long-term, but this is a privilege. It teaches you about the disease, and you become a better doctor because of it, in my experience. Who should see the neurologist? So complex presentations, if really there's a lot of symptoms that don't go together, or even if the patient wanted a second opinion in addition to what you're saying to form and strengthen that therapeutic alliance, well, let's ask the neurologist, let's see if everything we're saying is okay, if the patient needs that to understand that these are things that could help them. The advanced cases are harder, we can still help, but there is very limited interventions. But if at onset there are severe symptoms, definitely send them over. If there are atypical things like visual hallucinations, significant motor symptoms that are not arthritis, that seem to be a neurological disease, if there's a lot of language issues at onset, those are things to send. Everything that's atypical, that would be helpful to have a neurological impression. Younger patients, if they present young and they've got dementia young, it would be helpful to have them see a neurologist once you rule out the alternative issues. And then rapid progression, where truly from first symptom to dementia, 6 months or less. And then if you've done the first steps and there still needs to be more management or there's a lot of behavioral changes, definitely. That could be something we can help with. High stakes occupations, pilots, doctors, they may need more documentation. I've also included, and I'm going to leave you the slides, as to how I give memory medications. So cholinesterase inhibitors, mild moderate dementia, very helpful for dementia with Lewy bodies. I would avoid in frontotemporal dementia or patients who have a lot of behavioral issues. I would address those first. It can make behavioral symptoms in frontotemporal dementia worse. You all potentially have seen some of the GI side effects that these can cause, bradycardia, important people who have heart problems or who are on beta blockers. I will keep even if it doesn't seem to be doing anything as long as it's tolerated. Because sometimes you stop it and the patient drops, and then you can't gain that function back. So if you're tolerating it, keep it unless there is a contraindication. Donepezil is the most commonly used one. If that doesn't work, feel empowered to try one of the other ones. I usually try a rivastigmine capsule, and if that is not also, or if that is causing side effects, I go to the patch of rivastigmine. We have a donepezil patch, which is on paper great. It's once a week, but it's very expensive, and unless the patient can get a coupon, nobody can afford it. NMDA receptor antagonists, The main one we have is memantine. It's FDA approved for moderate or severe stages of Alzheimer's. It has to be dosed. The dose has to be corrected if there is eGFR less than 30, so if there's significant kidney failure. Dizziness, confusion, constipation, and sleepiness are the most common side effects. Sometimes it's used in vascular disease. Sometimes it's used earlier than the moderate stages. This one can have calming effects as well, so you can use it for that. Only keep this one if it helps. It usually has a very small effect. It has to be up titrated very slowly and down titrated slowly as well. Behavioral and mood changes, the cornerstone is never a medication at first. For behavioral changes, I often tell patients, you have sometimes, and families, more than patients, you have to learn how to speak a different language. You may not speak as fast as you used to before. You may not necessarily contradict as much. And then medication can be of help if non-pharmacological changes are not enough. I usually try newer SSRIs. I avoid tricyclics because they have anticholinergic properties, and paroxetine because they can make cognition a little bit worse. For more severe agitation, we have higher and stronger medication for Rexulti and also antipsychotics. There is an FDA black box warning. I would avoid strong anti-D2 action in dementia with Lewy bodies because that can cause a sudden cognitive and motor decline. Sleep hygiene, sleep psychotherapy is extremely important in early stages before medication. It can help even better than medication, but if medication is needed, I put in some dose recommendation, and again, I'll leave you the slides. I would avoid Z drugs, for example, Zolpidem. It's not ideal if you already have cognitive problems. Melatonin is great. It can also help some with some downing, and it can be very helpful in dream enactment behavior in Lewy body dementia. Trazodone, mirtazapine are good options if you need some sleep issues solved. And then this is the smart phrase I have. You probably have heard some of these websites and options. They have free classes online to help caregivers navigate some of the behaviors, demonstrate non-pharmacological techniques. You'll probably hear soon from another speaker of the planning options of advanced care planning. Use your local area agency on aging, get to know the people. They can be extremely helpful to get caregiver resources, facilities. You primary doctors sometimes are luckier than me as a neurologist. I still don't have a social worker here, so these are life-saving for me. But a knowledgeable social worker or case manager in your clinic can help you in very dire or sticky situations, caregiver burnout, when there needs to be institutionalization relatively quickly to avoid ER admissions. So use those resources. And with that, I went to the Seattle Art Museum last year, and there was this Hokusai exhibition. And this is obviously a cliche. I think everybody uses this picture, it's on t-shirts and everything. But I think it's a good representation of dementia too. You've got this big wave and, you are at sea and it's a storm, and it's not an easy disease to deal with as it gets worse. But there are boats, if you look closely, and there are people rowing to stay afloat. They haven't drowned yet. They're on top. And if you see in the background, there's Mount Fuji, and that was the artist's way to say, well, there is hope these people are close to land. And so the saying that should be your Mount Fuji is, you can see this through with them. And I always conclude there are ways to live a good life in spite of it. So I think that this is the optimistic way to look at it. And so I hope I've convinced you that there is an opportunity to be a Mount Fuji for people with dementia in their families in primary care. And that knowing your definitions and your vocabulary can give you like a way to deal with it in a more logic way, and to guide families, ruling out contributors and confounders. Usually those are not the cause, but if you can make it a little bit better, why not try? Prevention and lifestyle really matter for asymptomatic people. So you primary care doctors are the heroes of dementia prevention. Know your tools and use them. Don't be afraid to use them. Know what to avoid and know when to ask for help. And then I'll leave you with this. It's a little strange. Be the cockroaches of hope. Cockroaches never die. Somebody told me this in the neuro ICU when people came with subarachnoid hemorrhage, and some of the doctors and residents just threw their hands up in the air, say, there's nothing to do. Be the cockroaches of hope. What can I do to make it a little bit better, just for a little bit, you know? And with that, I finish, and I'm open for questions or comments. Thank you so much for your attention.
Dr. Russo, thank you so much for a wonderful didactic and reinforcing so many of the things that we've heard earlier today. Unfortunately, we're going to have to move on to our next session, but thank you also for kind of highlighting how cases get blended into this. So we're available for later questions. You can always reach out, but I think in the name of giving our other presenters enough time, we'll move on. But thank you so much.
Thank you all for listening. It was a pleasure to talk to you. Have a good rest of your session. Bye-bye.